Hello everyone, my name is William Derrick and I'm a second-year medical student at the Texas Tech University Health Sciences Center in Lubbock, Texas. Today I will be sharing with you a unique clinical presentation of a patient who experienced dysphagia and dyspnea due to an osteophyte between their C2, C3 vertebra. The patient was an 87-year-old man with a medical history of hypertension, osteoarthritis, benign prostatic hypertrophy, and multiple past hospital admissions for possible retropharyngeal abscesses. He presented to the emergency department with a 6-month history of shortness of breath and dysphagia. The patient had been admitted to the hospital 2 times in the month before this presentation, each time with similar symptoms. During the first admission, he was intubated and transferred from an outside hospital due to trouble breathing and stridor, with a suspected retropharyngeal abscess being the initial concern. Repeated CT scans of the neck during the first admission did not reveal a drainable abscess. Instead, they revealed the presence of subcutaneous emphysema and an anterior C2-C3 osteophyte. Based on these findings, ENT consult recommended IV antibiotics due to suspicion of necrotizing fasciitis. The patient was discharged with dietary restrictions after a 7-day hospital stay. The patient returned to the ED 2 days after being discharged with the same complaints. A physical exam revealed moderate respiratory distress and audible stridor, which improved when he assumed an upright position. CT scan of the neck showed a large anterior bridging C2-C3 osteophyte effacing the posterior oropharynx with no abscess. MRI imaging indicated an exaggerated cervical lordosis centered at C2-C3, accompanied by a large anterior bridging osteophyte. A consult with neurosurge was initiated, but surgical intervention was not recommended due to the high risk it posed for worsening dysphagia and the potential for spreading infection from the retropharyngeal phlegm into the spinal column. This patient was treated with corticosteroids and empirical antibiotics and discharged after another 7-day hospital stay. Finally, for this presentation, he was readmitted 9 days later with the same complaints, including shortness of breath and audible stridor. His voice was described by speech therapists as rough, gravelly, effortful with intermittent breathiness due to weak breath support for speech. And following a family meeting, it was ultimately decided to pursue home care with hospice for the patient due to his chronic upper airway obstruction resulting from the vertebral osteophyte. Now, why is this case interesting or significant? Airway compression with resultant shortness of breath due to osteophytes is rare. In fact, a previous literature review conducted in 2002 revealed only 4 reported cases since 1987, all of which had been associated with upper cervical osteophytes at C2-C3, like in this patient. In cases like those and this patient, the osteophyte intruded on the posterior or pharyngeal wall and larynx, causing an obstruction of breathing and swallowing. Other cases can involve osteophytes from C4 to C7, which intrude on the posterior esophagus, causing dysphagia, but in these cases, there is no airway obstruction. Cases of dysphagia due to osteophyte intrusion seem to be much more common. Treatment for airway obstruction due to an osteophyte includes surgical resection without fusion, but some patients, like this one today, was not candidates due to other comorbidities.